Hello, everybody. Welcome to the IOCDF Research Roundtable, the live stream where we take an interesting or hot topic in the OCD literature and talk about it with people who know it pretty well. My name is Kyle King. I'm a senior at Yale and an IOCDF National Advocate. And I'm interested in OCD both from a scientific perspective, but also as someone with the disorder. It has a lot of personal resonance with me, and a lot of things we talk about on the show strike a deep chord with me. As always, I'm joined by my co-host, John Abramowitz. John, if you'd like to say a word about yourself.
Sure. Thanks, Kyle. I'm Jonathan Abramowitz. I'm a professor at the University of North Carolina and have dedicated my career to studying and helping folks who have OCD. So it is a fascination of mine, and I'm really excited for this panel today as well.
Yeah, so today we're going to be talking about OCD and autism. And quite candidly, when I started as an advocate, I guess like 8-ish years ago, and really up until like a few years ago, I didn't realize how significant the connection between OCD and autism can be, and how many people in the community are affected by these two phenomenon. So I'm really excited to get to learn about the depth of the overlap and how the overlap's defined from people who know it pretty well. And the people who know it pretty well are our two panelists, Andrew and Rebecca, and I haven't introduced them yet. And they're probably looking at me and wondering why I'm blathering on so much. But I need to continue to blather for a little bit longer because I have some announcements that I must make. First, let me pull up my announcements page. There, okay. This live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Second, the IOCDF is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org. And then third, we have a chat feature, and we want to make sure that it's a safe place where people can ask questions. We really encourage you to ask questions. It makes my life a lot easier when I don't have to think of questions myself and just read what's on the chat. But just remember that everything that you put in there is online forever. And it's not being monitored when we're on live. So just be respectful and conscientious as you always have been. Okay, that officially concludes my blathering. Now it's time to introduce our guests. I'll start with Rebecca. She's on the right side of my screen, and she's the first bio that I have. So Dr. Rebecca Sachs is a licensed psychologist and an expert in the top recommended treatments for anxiety, autism, and OCD. She believes in empowering individuals and their families with knowledge and skills. Board certified in behavioral and cognitive psychology, Dr. Sachs was recently awarded a federally funded grant to the New York State Office of Mental Health, aimed at helping trained community-based service providers better serve children and youth who are duly diagnosed with mental illnesses like OCD and developmental disability. She has a private practice in New York and is a co-director of a successful school transitions, a comprehensive program for school refusal. In addition to these roles, Dr. Sachs is a mom to an energetic and determined 6-year-old and a stepmom to the coolest 15-year-old around. I like that ending. Dr. Sachs, I was trying to think of an interesting question to ask you guys to kick it off. I've been watching a lot of TV because I'm still on winter break. What's your favorite TV show of all time?
Oh, of all time? Oh, That's a really hard question. Of all, I'm going to not answer that question.
You're going to punt?
Yeah, I'll come back to it if it pops in my head.
Can I answer?
Yeah, go for it, John.
You answer.
Far and away, Seinfeld. And Cheers, but Seinfeld for sure.
Okay, that's a respectable answer. I can take that.
No, Seinfeld holds up. Yes, I agree.
Okay, but not totally agree. That's not your favorite either, or is it?
No. I'm trying to think. I don't know.
Okay, at the end of the show, I'll make sure to circle back and ask you again.
What I can say is I've been enjoying the new Percy Jackson series on Disney Plus right now. I never read the books, but so many of my clients actually have loved the stories Percy Jackson. So I've been enjoying watching it and can't wait when my daughter's a little older that I'll get to read the books. So it's not the question you asked, but I'll do it.
Close enough answer. I read the books a really long time ago, but I didn't even know there was a show about it now.
Yeah, it's good. I recommend it.
All right. Duly noted. Our other guest is Dr. Andrew Guzik. He's a clinical psychologist and assistant professor in the Center for the Treatment and Study of Anxiety in the Department of Psychiatry at the University of Pennsylvania. That was a long sentence. Dr. Guzik completed his doctoral degree in clinical psychology at the University of Florida, where he pursued specialized clinical and research training at the UF OCD program. He completed his internship at the Baylor College of Medicine, Texas Children's Hospital, and his postdoctoral fellowship at the BCM OCD program, where he was also on the faculty for 2 years. Dr. Guzik's clinical specialization is in cognitive behavioral therapy for youth and adults with anxiety and obsessive compulsive disorders, including exposure and response prevention for OCD. His research is focused on understanding and optimizing exposure therapy for children and adults with anxiety and obsessive compulsive disorder, low-cost and innovative methods to increase access to CBT, adaptations of CBT for anxiety amongst autistic youth, and patient-focused research for youth with misophonia. Dr. Guzik, I'm going to throw the same question at you. Favorite TV show of all time?
Yeah, I appreciate going second there so I could have a minute to think about it. It's funny. I kind of have two categories. So my category of can watch over and over again is like a comfort show is actually, I had Seinfeld in my head there. I just started rewatching Seinfeld. They put like Netflix on the Peloton recently. I don't know if y'all know that. So I've been doing a little Peloton Seinfeld combination.
Nice.
More recently, I was more recently, my shows I've been most into this year were The Bear.
Yes.
Okay.
And the Christmas episode is
my goodness. Yeah, exactly. So would definitely recommend folks check out The Bear if they're looking for a new thing to watch, if they don't mind. It's a little far from Seinfeld in terms of comfort food.
Yeah, I was gonna say, I don't think it's like Seinfeld.
Yeah.
I also want to throw in Daisy Jones and the Six, if folks have seen that. It's about a band. It's only 10 episodes, one season, and that's it. There won't be more seasons, but it's really good.
Huh.
I never even heard of that one.
Oh, yeah. It's loosely based on the story of Fleetwood Mac.
Okay.
Cool.
Yeah. And the music
You've been around longer than I have, John, and I've seen more shows. It's as if.
I'm trying to get, it's really dark in here, and I'm trying to get my light fixed.
All right. Well, why don't we get into the meat of today's program? I like to start off the show by asking general questions that tend to get me into trouble because they're way more complicated than I expect them to be. So for our two panelists, broadly, what is autism?
It's a good place to start. Rebecca, you wanna?
Sure, I can jump in. So, Kyle, I think you're right. You asked a very big question with a lot of different answers.
Yeah, I figured.
I would say very simply, autism's like a label right now that we use for lots of different ways and for lots of different reasons. That would be like my first answer. But for me, how I think about autism, and why maybe autistic people, come to me is it's a neurodevelopmental condition that basically we know individuals with this label process certain types of information different ways. So there are certain thinking differences, there are certain emotional processing differences, there are certain sensory, motor, and interoception, our internal feeling state differences. And there are also social communication differences. They're sort of the big ways that autistic people process information differently. And sort of what we would say is there are these core differences that we tend to see. They can play out very differently person to person. There's a lot of heterogeneity in autism. They can also play out really differently across the lifespan. So for one individual at different stages of their life, those thinking differences may play out differently. I see it more as a condition, these thinking differences, and that we can say is people tend to struggle because the world isn't necessarily built for these thinking differences. And that's where people may bump into problems, standalone autism. The other thing that I would say is, along with how these thinking differences play out, what we know is the amount of support that autistic people need can vary. So the DSM-5 talks about it in terms of like levels of support, like level 1, level 2, level 3, and thinking about people may need some support in communication, people may need some support in sort of flexibly moving through their day or at their activities of daily living. So like, just what I would say is adulting skills. And so you will see there's an expression, if you work with one autistic person, you work with one autistic person. That's definitely the case because of all these things that I'm talking about. And so when we also know someone has OCD or anxiety, how it sort of interacts with these thinking differences can be very, very different. Yeah.
Yeah. Okay. That was a lot of information to take.
Sorry, I tried to get, yes.
No, it was a good general overview. Andrew, do you have anything to add to that definition, or how you consider autism?
I suppose, I mean, it's a great definition. I really appreciate the appreciation that you have, Rebecca, I think, of the complexity and the differences. So you don't really want to nutshell it too much. And I think, Rebecca's perspective, if you don't mind me, I don't want to put words in your mouth, so tell me if I am, but it comes from something we were talking about before the panel started. A broader push from advocates in the autism community who have really fought for autism being viewed this way, as a condition and as a difference that they experience that is incongruent with the way that most other people see the world and experience interactions and relationships, which can create challenges. And that difference, we're thinking about autism as a difference in identity, the same way we might think of ethnicity or religion or race as a difference in ethnicity. It really changes your whole frame of how you think about it, because you don't want to necessarily, the way that we want to treat the core features of OCD. People suffer with obsessions and compulsions. There's lots of parts of autism that advocates on the spectrum will tell you, this is a part of my identity that I love. I have focused interests in this particular topic, and I love that I can just invest all of my energy there. And we don't want to pathologize that. And at the same time, given these differences in how we perceive the world, there's going to be some real challenges with that, not only because of how the world's set up, but also because some of the core traits of autism, for example, an insistence on sameness is a really common feature of autism. That overlaps a ton with OCD and anxiety. The needing things to be the same, needing to know what's coming next, needing to have not things change in what can be a rigid way. That overlaps a ton, sometimes maybe with a compulsive need for certainty or compulsive just right routines. And so that's the part that we want to start thinking about, at least as a psychologist who specializes in OCD and anxiety. That's what we want to start thinking about really addressing, but not so much the core features of autism. And that's also, I'm not 100% answering your question either, but I guess building on what Rebecca was saying.
Yeah, definitely making the question more complicated. Okay.
You did tee us up for that, I guess.
Yeah, I did. That's my bad. I have a couple different lines of questions that I'm trying to think of which one to go down. I'll start with the broader. So you kind of talked about these like core features of autism, which like the broader movement within the advocacy space would be like, we're not going to pathologize these sorts of features. Rebecca, as from a clinician's perspective, I guess like how would you describe treatment for autism, or is that not even the right way to frame it? Is not being treated?
Yeah. So I would say most people who come to me aren't coming directly because of autism. They're coming to me for treatment of OCD or anxiety. And they happen to be autistic. And so I still believe CBT with ERP is probably the most powerful, I would say, intervention for anxiety and OCD. It just requires for autistic individuals some like modifications in order for it to be delivered and most effective. But I would say people aren't coming to me to treat the autism. What I may sometimes have is that autistic individuals who don't know that they are autistic or don't understand what autism means, or their family, or like their systems around them. The school doesn't really understand how can we support those differences. You will then see a higher level of sort of what I would call almost reactive anxiety, different than what I would say is like a core anxiety disorder. But like life just feels inherently dysregulating, or even worse, traumatic, because there's a lack of understanding about how their brain works and probably what are more effective ways. And so when people come to me without sort of like a standalone anxiety or OCD diagnosis, and it's more the dysregulation they're experiencing is because of the lack of knowledge, that's where I would come in. But it's not really treating the autism. It's more empowering individuals to understand how their brain works, and also understand how to maybe get certain accommodations and make certain asks, and also then how to push themselves, how they may thrive in predictability, right? And you want to accommodate that, but also how can they have the bandwidth and the skills to deal with life situations that may not be able to be as predictable.
Okay.
I don't know if I answered your question.
No, you did. And you lent more questions. John, do you have any questions?
Well, I was going to ask and kind of go in a different direction in terms of like the boundaries between OCD and autism, because I think sometimes there's confusion because folks with autism have, what can sometimes seem like obsession-like, preoccupations with things, and sometimes can engage in a stereotypical behavior that can look like compulsions. And I don't know if you wanted to go there now, but I was curious about, what folks think about the boundary between those two.
Yeah, I was going to go there now.
Oh, great.
Yeah.
What's your mind?
It's a great question. And I mean, ultimately what we're talking about is repetitive behaviors and repetitive thoughts. And, when we think about the concept, there's some clear differences in terms of what's core to each. In OCD, repetitive thoughts are intrusions. They're unwanted, uninvited thoughts that really cause me a lot of distress. In the repetitive thoughts in autism, we often think about as fixed on something that's giving a lot of joy or a lot of pleasure. Maybe it's a focused interest. That said, there's a clear tendency towards perseveration among autistic individuals. So that same quality that can get someone stuck on, cars or horses or Minecraft, when it starts to flip and center on an intrusive thought, it can really ramp up OCD in a really dramatic way. And this is one of the reasons that we see an overlap. Is one psychological overlap is that perseveration. And so there's these distinctions, but then there's times when they come together. And same goes on the repetitive behaviors. In OCD, it's a little bit more simple. People engage in compulsions because they want to relieve distress associated with an intrusive thought or feel safe. And in autistic people might engage in repetitive behaviors for lots of reasons. They might have, we're talking about a kid we had in a project yesterday, had a straw, a very particular straw that he had everywhere. And we kind of figured out this was maybe serving a self-regulatory function. Or they might engage in repetitive behaviors. Let's go back to like an individual who's really into horses. They might line up their horses and maybe read the page from a favorite story over and over again because they're enjoying it. Or maybe they're engaging in a behavior because it gets them out of something that they're not enjoying, and they don't have a way to communicate that very easily because there's difficulties communicating verbally. Again, though, we can see this repetitiveness can overlap, and while they can be very distinct, like I'm describing, they can overlap too. And so I'll give an example. So we have one person with OCD who's reading a page over and over because they feel like they need to understand what each and every word says, and I need to get that just right understanding. And if I don't, then it'll be really bad and I won't be able to move on. Someone maybe could read the same page just because they want to relive the story over and over again. But then we can have somebody where there's a little bit of both. You know, I'm rereading it over and over because I love this book, but if I don't understand everything just right, then that would be awful. And that part is when we start, you know, if there's any OCD compulsive in there, then we can call it both. And that's why there is this overlap, is because it is often both, and they do overlap to some extent.
Yeah. I may add like two things that you had talked about at the beginning, Andrew, but I think when I often think about, especially parents are coming to me and they're saying like, well, what is OCD and what is autism? I don't want to change my kid. I don't want to interfere with their passions or change their personality, but I also don't want OCD to go unchecked. I sort of have two things that help guide me. One is definitely this idea, like in the language we say ego syntonic or ego dystonic, but really what it means is when the person does the behavior, the repetitive behavior, is it more for like relief or is it more for like pursuit of enjoyment? When it's more for pursuit of enjoyment, we're thinking typically more that like autistic repetitive behavior. And usually when it's like some kind of relief or, you know, going down of our discomfort, more likely we're in OCD land, I say. The other thing that I see is that, you know, OCD typically has certain content areas. And while OCD sometimes strays outside those content areas, we know like fear of harm, contamination, I would say like uncomfortable or taboo thoughts. Those are just three. Those content areas, even though sometimes the obsessions maybe have an atypical sort of presentation to them for autistic individuals, you'll often see still the OCD fall in those content areas. There is one, Connor Kearns has done a lot of really nice research on showing how in autistic youth, the anxiety and OCD presentations may look a little atypical than what we would expect for a non-autistic youth. So sometimes even just like going to the literature and being able to see that saying, oh yeah, no, this is OCD or this is anxiety. It just, the flavor's a little different, but still in that content area. So that's often how I think about those differences. But Andrew, what you were really saying is, we don't always see these things fall in these perfect boxes. Yes. We're often seeing them like entangled with each other. And this is, again, where I always think about OCD is like a brain and behavior like disorder, right? Like you have these obsessions, but really what we're always like concerned about is the compulsions, right? And those are the behaviors. And because when we do these behaviors, we learn in a certain way, like we get a certain feeling. And so when we know an autistic person may have sort of their passions entangled with their compulsions and they're doing these behaviors, they're still learning. And so sometimes we still may need to say, hey, this used to be a compensatory strategy for your autistic thinking differences, but now it's no longer serving you behaviorally. Now it's no longer broadening your life or making your life easier. If anything, it's now become a habit that you just feel like you have to do and it's not serving you. And that's sort of where we would come and intervene in that way. Similar to ERP. Yeah.
Is in the case that Andrew is describing, like where there's someone who's reading a book because of maybe their interest, but also there's like some OCD woven in where they like need to read again and again. I'm still kind of a little bit confused about how like you would approach that from a treatment perspective, and like tackle the OCD, but not the autism. And I'm using kind of this black and white language, which is probably wrong too. That's the only way I know how to refer to it.
No, I think it's a fair distinction in the sense that we've really set this up, I think, to say a compulsion is something that we want to help someone overcome, and a lot of the time autism not so much. So I think that's a fair differentiation you're describing.
Well, and I think that Andrew's example was kind of not necessarily it would be happening in the same person, but just to kind of show that, here's the difference between autism, how that presents, and how OCD would present but it could look the same if you just focus on rereading and thoughts, right? We have to go beyond the mere presence of repetition.
Yeah.
We have to look at the function, I think, is what Andrew and Rebecca are both saying. It's not so much about they think they get stuck on the same thoughts or they get stuck on the same behaviors, but also why they're doing it. What's the motivation? What's the function?
But it sounds somewhat fluid. Like one can, repetition over special interest can then sometimes go into the realm of OCD, unless I'm misunderstanding it.
No, yeah, absolutely. Sometimes it is nice and clean like that, where we see the same behavior, but the function is different. And so we can very clearly put it into one category or another. And other times, as Rebecca said nicely, they're entangled. And so, how would we approach that as a exposure and response prevention therapist? We'd really try to pull out as best as we can. And maybe, and a lot of the time I work with kids a lot too, and that it tends to be the case among people focused on autism, although it's a little bit of a limitation in that area. Usually the kid research lags behind adult, and autism, it's like way in the opposite direction. So it's a little bit of an aside. We really need a lot more work in that area. But that said, a lot of the time, a kid in particular won't be able to tell you very clearly, oh, I'm reading this page over and over again because I love it, or because if I don't, it'll be really bad. So you have to work with the parent. You have to test things out. You go into it. You see what happens. If we can introduce a little flexibility, what if we skip this line? What happens? If there's a major expression of distress, it seems to me like this is limiting flexibility, limiting a kid's ability to really thrive in a variety of environments. And so that's what we might want to start challenging with exposure and response prevention. And if a kid really doesn't see the point of it, which might be the case, particularly, if I'm on the spectrum and I don't really understand how emotions work very well, and I can't really point to, whether this is serving me or not, then we need to make sure that we're respecting that and saying, hey, this is we understand this is really hard work. And so what's in it for you if you can overcome this, and think about what can motivate a child, for example, to really tackle their fears.
Yeah.
What's the prevalence in kids and in adults
of autism and OCD?
Well, actually both, so it's of autism by itself and then also the overlap. What do we know?
The autism, it gets more and more every time you turn around. So the most recent CDC number that I'm aware of says that it's 1 in 36 kids now, I believe it is. And that's in kids. I think that the estimates are probably not as reliable for adults, but there's no reason to believe it's any different in adults, because it's neurodevelopmental, should be there from early on if it's there. And as an aside about that, I think there's a couple reasons why the prevalence is increased compared to, a couple decades ago. It was like 1 in 100. One is recognition, and a lot of diagnosticians, I think, are expanding their boundaries of what makes it into that classification. And two, there's something to this idea of, there's like something in the water, that there truly is maybe an increase in true prevalence, even if we would have counted the same thing a while ago. There is some argument to be made. I'll give this does not account for this dramatic change, but it's just an example. There's some evidence to suggest that when older dads have kids, they're more likely to end up being on the autism spectrum. And dads are tending to have kids older at a later age now than they used to. So, there might be lots of factors like that at play, but I don't think we have our arms around it quite yet. I think and more of it's accounted for by the recognition and expanding the boundaries.
Yeah. Well, and I would say, so one is, in 2013, when we went to DSM-5, we changed from all these distinct diagnoses to just a broad umbrella. And there was definitely like a broadening of like the criteria. So more people who probably wouldn't have gotten an autism diagnosis were more likely being properly captured. There's also been, I think, increasing research on autistic presentation in girls and women who on more traditional kind of measures were often being missed. There's been a lot of talk about sort of TikTok and self-diagnosis. And I think that's a whole nother live stream that we could get into about this. But one of the, I think, benefits is that people who rightly so are probably low support need autistics who are doing a lot of social camouflage and masking and wouldn't traditionally have gotten a diagnosis are actually self-advocating for themselves in a process to get the diagnosis. And I think part of that is also what's happening. We also know is that traditionally certain socioeconomic and racial groups, for when individuals were autistic and had intellectual disability, were more likely just to get, it used to be MR is what the research is, but get an ID diagnosis. And now I think thankfully that's shifted a little bit more, where people aren't just getting the intellectual disability diagnosis, but are also properly getting the autism diagnosis along. So there may be something in the water, but I also think we're just getting the label properly attached to the individuals who it helps explain sort of some of their challenges and what's going on.
I think that's.
You were asking also how many individuals who are autistic also have OCD, correct? Or
so I'm just curious. One more question about prevalence. This is really interesting.
Yeah, really interesting.
Yeah, worldwide, about the same in other cultures, countries, and also on the increase.
Yes. Yeah. If you do look at the WHO, they're, while I think it's not the same as 1 in 36 as the CDC, you have been seeing that it's been increasing globally as well. Yeah.
And John, is that the case for OCD as well? Like just OCD isolated?
Say, what's the last part?
Like, have estimates of OCD prevalence also just been rising for, I guess, maybe for some of the similar reasons that Rebecca was talking about?
Not that I'm aware of. It seems to hang in that like 2 to 3%. There's variation around that. Some a little bit lower, some a little bit higher. But not as much. Now, I do think there was a similar rise maybe 30, 40 years ago. I think like in the 80s, some of the medications came out which drew a lot of attention to OCD. I think that like in the 60s and 70s, people thought like 1% or so, and now we know that it's a lot higher than that. But so it might be something similar that happened along with recognition, kind of like what happened with OCD maybe a generation ago.
Right.
Yeah.
But I think even more what's interesting, which I'll piggyback on this, is autistic individuals experience mental health conditions not only at a rate similar to neurotypical people, but often at a higher rate. So what we know is autistic people are probably more likely to have anxiety and OCD than a non-autistic person. And I think traditionally, just sort of the way our training systems have happened, the way our hospitals and our programs are structured, and just also how people got services. There's often been a siloing. And so if you go and you get like autism or developmental disability services, you're usually not getting mental health treatment. And if you go to a mental health provider, not everybody often understands how to work with autistic clients. And it's a real problem, because if you're saying is they experience OCD at higher rates and then it's harder to access care, then not only are people being undertreated, what we know is just get an OCD, I don't know if that's, an OCD diagnosis and proper ERP treatment can often take years and years and years. You can imagine what's going to happen to an autistic individual. And we all know how OCD works. It's not like OCD magically just sort of resolves and gets better. Often we see like, the snowball running down the hill and the compulsions become even more and more and more intractable, which is why I'm so glad the IOCDF is like bringing this topic out so we can hopefully get people to treatment earlier. And prevent that severity.
Good point.
So what is kind of like the prevalence of autism in folks with OCD and vice versa?
it's hard to do those studies, but
I imagine,
especially on the how common is autism and OCD question, because autism is among our most complicated diagnoses to make clinically. So I think the numbers that they tend to hover around when you look at like elevated scores on a validated autism assessment, if you look at a bunch of people with OCD, it's usually around 10% or so have elevated autism features. Now it's higher if you do it in the reverse direction. If you assess OCD using validated measures among a big autistic sample, it's closer to, it ranges a ton, but the average is somewhere around 20%. The reason it ranges a ton is because there's a wide range of verbal abilities among autistic individuals. There's a lot of nonverbal folks on the autism spectrum, a lot of autistic individuals who have an intellectual disability, and our assessment methods, are usually not validated very well for those sorts of populations. Not to mention, Rebecca was citing Connor Kearns's work, which is really noted that we really need to be modifying our assessments of anxiety and OCD among autistic individuals. So a lot of these assessments aren't really tailored. All that said, all those caveats said, let's say 1 in 5 is like a number that I feel pretty okay about in terms of how many autistic people have OCD. It's pretty common.
Can you say something? I think folks would be interested in learning about what are the tools that are used to make a diagnosis
for autism.
Yeah, for autism.
Yeah, it's usually to do a really gold standard, super high quality job. First and foremost, you need to go to a professional who has really good experience in autism diagnosis. As I said, it's one of our more specialized areas. It can be. At the same time, we don't want to dissuade clinicians who are educated and well-trained to make an autism diagnosis when they're confident in it. But if there's any sort of questions about differential diagnoses, then it involves a really detailed history, as much as you can, collateral information from teachers, from parents, observations of the child, use of validated interviews and questionnaires. And in a real gold standard sense, there's a validated assessment that involves a lot of interaction with the child called the Autism Diagnostic Observation Schedule. And that's really our highest standard. That's an in-person where there's a lot of communication and relationship sort of assessment that comes into play. And so, yeah, to do that gold standard job, it does take some doing.
The like other gold standard that we talk about that's research reliable is also the ADI, which is an interview format, where if for whatever reason you can't administer with a child, or if we know that a child is probably twice exceptional, so gifted as well, and may not ding in the same way, or especially as an individual is older, sometimes we'll rely on the ADI like as a gold standard measure. I'm gonna pop also just a it says connect to. I don't know how to join the chat.
You might be able to put it in the private chat then.
All right, I'll put it in the private chat. This is also, I feel like this is a book that I like. It's for adult assessment. Mm-hmm. So for individuals who maybe didn't get a diagnosis earlier on. And again, I would say these are like level 1 lower support needs autistic individuals, but maybe people who are going to come in first for anxiety or OCD treatment and not necessarily know that they're autistic or suspect it. This may be a nice resource for clinicians to use that could be helpful. So I agree, Andrew. I would do like a very, very thorough developmental history, social history, sensory history, academic and educational history. And a lot of times I'll find I'm working with families where they're coming to me and they're saying, I just don't understand why they're not moving through in the OCD treatment, why it's moving so slowly, or why they seem stuck. And, there are enough like flags there that make me think autism. And I start doing my, history taking. And one of the first questions I ask is like, did your kid receive any services when they were younger, like early intervention? And lo and behold, I'll find out that yes, the child was given a label of PDD-NOS, pervasive developmental disorder not otherwise specified, which prior to DSM-5 was a diagnosis that was given that's now under the umbrella of autism. And these people probably did have a diagnosis of autism or similar to it. And then 10, 15, 20 years later, they've sort of been bumping their heads not knowing they've been autistic. So I do think even asking about that is often very, very helpful. You'll find the data is already there.
Yeah, I was wondering kind of, I think we've or Dr. Tex, you've alluded to this in some ways. Does exposure change at all? Like ERP change at all for an autistic client, or is it the same?
It's really just modified. What's interesting is from all the research that we do have, we know is that the most essential ingredient for treatment of OCD in autistic individuals is still exposure, right? Like and it's interesting because I think a lot of clinicians out there do relaxation and PMR and other things. But we know ultimately you could ditch relaxation and other parts, and you really just have to do the exposure. It's how do we get to the exposure? So there are definitely going to be, and I think as a behaviorist, there are going to be things we do before the exposure to help create predictability, to help give agency and choice, to help sort of them understand what's going to be happening. And so the delivery of that is going to look a little different. Also, when we're doing the exposures, most likely we're going to go a lot slower in our pacing. And we're also probably going to start way, way lower on the hierarchy. We might even ditch SUDS. We're less likely to really think about habituation, and we're really going to do more of a distress tolerance model. Sometimes habituation can take hours and hours and hours in our autistic individuals. We also usually we don't do like what we would think about is counter conditioning for most of our OCD clients, but especially when there's intellectual disability, we may also want to present sort of positive or reinforcing stimuli. So like bubbles or stickers or songs, because we usually shy away from something that may seem like distraction or taking away from the full distress, but we may find like when we're delivering the exposure that that's needed. I almost think about it again from a behavioral perspective is we're just doing continuous reinforcement. Oh, you're engaging in the exposure and the distress. Here's your reinforcement. You can almost think about it that way. That's maybe how the exposures would look different. And then we would think about what follows. The exposure may look a little differently as well in terms of rewards. The other thing, just to go back to exposure, sorry that I'm realizing I'm trying to package as many modifications quickly. You may not want to do pure response prevention. You may be starting off more with like ritual delay or ritual like shortening at first with when we're doing exposures, and then build upon that to do full response prevention. Those I would say is some of the big modifications I would think about.
So Matthew Bannister at 1243 just asked a question that's probably worth talking about. I think I know the answer, but I'm curious what you guys would think. Would ACT be a good addition to ERP for someone who has autism and OCD?
I would say depends on the client. I would say probably for our more verbal clients, in terms of getting that hook for what is motivating and relevant to them. Definitely, I think ACT would be nice, but I think for our less verbal clients, ACT probably wouldn't. And if anything, for our less verbal clients, we would want to de-emphasize the cognitive components of CBT and just do more of the behavioral components and include more family stuff.
Kind of goes back to what you said earlier about you've met one person with autism.
Yes.
I'll add on the cognitive component as well, just to really emphasize that point. We did an analysis of a big trial of autistic kids with OCD and anxiety disorders, and we looked at the rates of change in different phases of treatment. And we basically replicated an analysis that had been done in non-autistic kids. And what they found is that over the course of CBT, during relaxation, no real change. When you introduced cognitive strategies like reframing, challenging thoughts, things got a little bit better. And then improvement really takes off once you start exposure.
Yeah.
We looked at autism therapy the same way. And we actually found that when you started, there was a slight improvement when you started psychoeducation, relationship building. And then you introduce the cognitive strategies, and there's literally a deceleration of improvement in this trial with 160 kids on the spectrum. And then we started exposure, and again, improvement really took off. So this is just to say, for a population who, generally speaking, in large part, there's going to be challenges with rigid thinking, and there's going to be challenges with verbal communication. In the OCD world, the consensus has come to say we need to emphasize exposure. I would say with autism, it's even more important to, and just, I guess, to really underscore that point.
That experience really is the best teacher.
Exactly. You got to walk the walk, right?
And I guess Rebecca and Andrew as well, like when you were talking about kind of strategies to help make the exposure process, I guess, better for an autistic client, with like helping them kind of understand, like, or get a better sense of like the plan and stuff, like what are some concrete ways a clinician could, I guess, improve ERP for an autistic client?
We
or is that like a one size fits one kind of question where there's no really strategy?
To be a clinician, you always got to think that way, no matter what. That's part of the fun and part of the joy. And clinical work is figuring out how to reach and how to connect with every individual who's different. But there are some general tools of the trade that we can borrow from that's lived in more of the autism world. Like, for example, we just did a qualitative study where we interviewed parents and frontline clinicians and all sorts of folks who were constituents in this autism group. How do we need to adapt exposure for autistic individuals? And one concrete recommendation was visual schedules are used all the time in all these other autism services. And when we're in therapy, we never see them. And I'd really like to see, we're going to start off like a clear visual. We're going to recap homework. Next, we want a clear visual for a child, for example, of say, if it's a contamination exposure, a picture of the toilet. And then, to finish it off, we're going to plan homework. And having that in a clear visual way, for example, for kids, is just like a nice concrete example of a way to incorporate predictability, as Rebecca said, which is just going to set you up for success.
Yeah. Andrew, as you were, I was writing like my notes on like what I wanted to say, and visuals was number one. Yeah. Visual presentation of information. Like you can't do enough of it. One also in visuals to help like understand a concept. So there's also something called social stories, which people can learn about and clinicians can learn about, which is often a way of introducing, and you can also do social stories for adults. It just would look a little different. But it's basically when you're presenting new information or maybe emotionally fraught information, which would definitely be an exposure of, it's sort of like a clear kind of way how you're saying, here's what you're going to expect. Here's how you may feel. Here's what you may want to do. Here is a good behavioral choice of like what's going to be helpful to you and what to expect. And you would do it in visual format, either just with words or with pictures. And yes, having an agenda for the session. I would also say choice is going to be hugely important. We know as therapists, there's probably 500 things we always want to accomplish in a session. And so like giving our clients a little bit of choice, maybe out of these two, which one do you want to do? Which is why a lot of the research that's going on in treating OCD with autistic youth often has a modular approach, and you can almost shift in and out with the modules about what you're going to use. And you can also let your clients have choice. The other thing that we haven't talked about, which I think is huge for autistic clients, is what is typically called special interest or preferred interest. I like calling it passions. You know, OCD and autism are my passions, and I could talk about it for days and days and days. Our autistic clients definitely have clear passions. And I think often when I'm first working with trainees, they're like, how do I get this person to not talk about their preferred interest? How do we get to the exposure? And I said, you're wrong. How do you talk about their special interest and incorporate it into the exposures, right? And I think that is a huge modification. It shouldn't just be used as a reward. Like, if you do this exposure, then you get to tell me all about Pokemon. That let's be using Pokemon or whatever it is into our exposures, which is why, Kyle, your question at the beginning, what's been our favorite TV show? So if I was doing exposures with John, I would be using a whole lot of Seinfeld, right? Like, you know, I would, if we're doing food exposures, I would be playing, these pretzels are making me thirsty. I would do the seltzer salsa, and I would be using all of this kind of stuff in our food exposures. And hopefully that would get John excited to be doing exposures a bit more engaged. So, yeah.
It took me a minute to catch the Seinfeld reference.
Yeah. There are more. I mean, there's also the babka. We could be doing a lot of.
We could do food exposures with soup.
George was eating the sandwich while watching the game. I mean, there's a lot of exposures we could be doing. Yeah.
I want to turn to the chat while we have some time left. Kelly at 12:38 asked, what about adult diagnoses with teachers and parents growing up were ignorant and stigmatizing? She asked this question when we were talking about assessment for autism. And this is a question that I thought of, like, if you're an adult and, like, I guess you're kind of past the point where you have kind of like teachers and parents who are watching you all the time, how would you go about getting assessed for autism, or is it the same?
I'm not sure if I understand the question exactly. When saying, how would you get, are you saying as an adult, if you have had invalidating experiences growing up and didn't get a diagnosis, how would you get a later in life diagnosis? Or
I think that's more or less what the question is. Or does assessment for autism change when you're an adult versus
not necessarily. So I think, you know, at the end of the day, to get a diagnosis of autism, you don't even need an ADOS, you don't need an ADI, you don't need a gold standard kind of thing. What you need is clinical judgment by someone who can give a diagnosis. I would also say is, you know, neuropsychs are very, very expensive. And so to have all that formal testing, is it necessary? It may become more important if you're trying to pursue services. So if you're still in school and want an IEP or accommodations in college, or if you're pursuing like Social Security and other kinds of statewide supports, they're going to have certain kinds of documentation that they require. But there are lots of different measures that can be used to try to capture the experience of an autistic adult, along with what Andrew exactly said, really just a good developmental history in terms of getting at it. Yeah,
I think, you know, I see Kelly is following up to clarify her question, and it sounds like it's coming from some personal experience, and is concerned that that history won't be congruent with an autism diagnosis. And you know, please jump in, Rebecca, with your thoughts as well. But ultimately, if you if you see somebody who does consider autism diagnosis in the scope of their competence, maybe they're a neuropsych expert, but maybe they're someone who just knows a thing or two about autism and is confident and doesn't see that as necessary. If they have information from you, collateral information as best as possible from, say, parents or people you trust in your life who knew you as a kid, who can give good descriptions to the answers to these questions, it won't just rely on a teacher saying you got good grades and there weren't problems in the classroom. Yeah. To Rebecca's point earlier, maybe, you know, there can be some gendered aspects of of like the emotion dysregulation expressions of autism. And so continue advocating for yourself, give the best answers to those questions as possible. And I would feel empowered to express that concern you have. Listen, I did well as a kid, and here's the other things that make me wonder about this. And if it's somebody who's competent, then and confident in that ability, then that's their job, is to suss that out.
Yeah, and in terms of social camouflage or masking, so there is a good book by Devin Price called Unmasking Autism. I would read it. And like there are lots of things that can also help you even identify the process in yourself, but then be able to articulate this in like an intake. There's also Baron Cohen has the CAT Q. There's no like cutoff on the CAT Q, but you could still fill it out and use that information to better understand if a person, like how they're camouflaging or masking. I find that for a lot of like lower support, high masking individuals who are also verbal, that the RITVO or the RADS is you could either fill it out on your own, or it could be used in an interview format, often captures diagnostic history information for those individuals who may not ding, like you were saying, on Mod 4 on the ADOS in that way. There was also an article, I'm just going to see if I can get it up, that talked about like pink flags of autism as opposed to red flags of autism, and how if you're a clinician, seeing like what may be sort of sub-threshold or threshold things to be looking for when you're making a diagnosis. I'll see if I can get that reference and put it up. But those would be things that you could also like bring to the process to say is, hey, look, I do fall into these categories. And this is a research article that really talks about this in these ways. So
yeah, I want to see that pink flag article. John, I have one more question. We're running out of time, but I want to give you the floor.
Yeah, I'm sorry. My computer decided to randomly restart. So I dropped off. No, go for it. I've been fascinated by the discussion.
Yeah. I just because, I like the brain stuff. Have there been studies to look at kind of neural overlap and neural correlates of these two phenomenon?
It's a great question. There certainly are, and I could do my best to try to give a neuroscience based answer to overlaps and differences. I fear that I would be giving an incomplete answer. I can send you a good citation though, or for others who are interested. That looks like it was a recent paper piecing those things apart. Rebecca, I don't know if you have anything else to add.
I would say yes, there is, but no, I am not competent enough to speak to it. I do know at Columbia, is his name Vanderweel, I want to say, has done, I may be botching up the last name, but something like that. He's at Columbia and he's definitely done some research, but if Andrew has like clear references, then I would say to look at it. Yeah.
I sent in our private chat here. I sent a meta-analysis I came across that looked at differences, and that the overlap, as far as I can tell, are a lot of the things that we see across psychopathology. There's really impairments in the top-down regulatory functions, particularly here in the dorsal anterior cingulate cortex, the medial prefrontal cortex, and where things get a little bit different is kind of in that subcortical area, but they result in some of these same inhibitory self-control differences, which is why I say you see repetitive thoughts and behaviors in both. That's my 10,000 feet explanation. I won't try to go much deeper than that because I'm sure I'll get something wrong.
Yeah, no worries. Okay, well, since we're coming up against time, I wanted to ask you guys kind of what's something you want viewers to take away, because we've talked about a lot of complicated things. I'll start with you, Andrew, because I think Rebecca's still looking for the pink flag article.
Sure. I'll if there's any clinicians out there, I want to empower people who are OCD experts to welcome those on the autism spectrum into their practice. And because it is such a common aspect, the fundamental aspects of treatment for OCD among autistic individuals are the same. Their exposure and response prevention is your key, and there's great help out there. And I guess that goes to anybody who might be listening who has personal experience with one or both of these concerns. exposure and response prevention, I'm biased, but I also like to think somewhat realistic, is one of our better achievements as a field in terms of really helping people. And it holds up when for people who are autistic, for people who are not autistic, across the board. And we now have compelling research to suggest that. And so there's reason to be hopeful and to get connected with the many, many resources IOCDF has to offer, for example, in terms of Find My Therapist and all Find Me a Therapist stuff and whatnot.
That's a pretty solid answer. And you, Rebecca? Well, first, actually, do you have a favorite TV show in mind?
I still don't know if it's favorite, but I would say when I heard you guys say a show that you could keep on watching over and over and over is 30 Rock. I have watched 30 Rock
30
like
Rock.
over and over. And every time it just like season after season, it cracks me up. So if you had to pin me down right now to something, I might say that. So, but I'm a little non-committal. There's still, you're going to have to tolerate the uncertainty that I may not have a perfect answer.
Fair enough.
So.
And then what's one thing you want to say to our viewers to take away?
I would just say is that at the end of the day, OCD is treatable in autistic clients, and that I think if you are good as a clinician at delivering ERP, you can be excellent at also working with autistic clients. It's just understanding a little bit more. I would really just say is, and how do you get better at knowing how to work with autistic clients? Really listening to autistic people and your autistic clients. Like do a lot of listening, I think is like the best first step to saying, how am I going to modify this? Because you would do that with other patients and then figure it out. So it's just like, it's just, how am I doing it for this person? Yeah.
Flexibility within fidelity, right? We know.
Yes.
We know what are the important mechanisms that we need to get someone past OCD, but how do we be flexible in the way that we implement it so that we can, get there?
Yeah.
Meet the person.
Yeah, help as many people as possible.
Yeah.
All right. Well, thank you both for a really interesting live stream. We have a live stream survey, or the IOCDF does, that I just sent, I think. Yeah. Oh, no, it failed to post. But there's a live stream survey, which I think Brendan's going to put in the chat, where you can request different live stream topics. And also you can give us feedback on our live streams. Now, Brendan put in the chat. There's also a bunch of live streams, and you can go on the icdf.org/live streams, see the entire schedule. Thank you again, both to Rebecca and Andrew and John, for being on today. And we'll see you next month.
Bye, everybody.
Thank you.
Thanks for having us. It was a great conversation.